Hello, welcome to a new episode of discussing the most important MCQs for nurses, those who are preparing for NORCET or any nursing competitive exam, including NCLEX. So, without any doubt, we can move on to the questions. The first question: identify the mechanism of action of heparin. So options are: heparin inhibit the hepatic synthesis of clotting factors. Heparin binds to antithrombin 3 and increases the inactivation of clotting factors. C. Heparin inhibit the vitamin K dependent carboxylation of glutamate residue of clotting factors. All of the above. So guess what? Option B, that is the action of heparin. Heparin binds to antithrombin 3 and increases the inactivation of clotting factors. Question number 2. Warfarin should not be given to the thrombotic patients with coexisting what problem? Renal dysfunction, hepatic dysfunction, pregnancy, both hepatic dysfunction and pregnancy. So guess what? Both hepatic dysfunction and pregnancy. In pregnancy, it is absolutely contraindicated, when a person on warfarin therapy become pregnant, the warfarin will be switched to heparin. Also, oral anticoagulants are not preferred in severe cirrhosis or in moderate to severe cirrhosis of liver. Confirmatory sign of endotracheal tube intubation is capnography, visualization of vapor in the ET tube, chest expansion, carotid pulse. Guess what? What is considered to be the confirmatory sign? Exactly, it's capnography. So what do you mean by capnography? Capnography waveforms you can see in the monitor, which is actually showing you the number of it actually showing you the measure of carbon dioxide in the expired air, or also the inhaled and exhaled carbon dioxide graphical representation is what you see in the capnography waveform, which both includes a number as well as a waveform. So when an ET tube is placed, what all are the things that is considered to be the confirmation? Previously, condensation in ET tube, increase in the heart rate, equal breath sounds in both the side when you auscultate with stethoscope, kinetic chest, which means chest expansion, kinetic related to movement, so chest movement, and capnography. These were considered, but now actually condensation in ET tube is not considered. Reason is, even if the ET tube is in the esophagus, sometimes the condensation can be seen, so which is not considered to be very significant. But these things are still considered to be important. But among all, you can call capnography or waveform capnography as a gold standard in confirming the placement of ET tube. Other things are glottic visualization, flexible endoscopy, and POCUS. POCUS is point of care ultrasonography, which usually done by emergency treating physicians at the bedside of the patient. So in order to make quick clinical decision, not to wait for the radiologist to come and do the ultrasonography, in those cases or in those scenarios, to take quick decisions at the bedside of the patient, the ultrasound that's performed is called point of care ultrasonography or POCUS. These four are considered to be important measures of confirming ET tube placement. Among all, waveform capnography is considered to be the gold standard. Now, ET tube placement level is at the level of carina, 1 cm above carina, 4 cm above carina, at sternal angle level. So, what is the level? Guess? Yes, C, 4 cm above carina. So, carina is the point where trachea bifurcate into two bronchi. So, if you fix at or beyond carina, what happens is air entry may not be equal to both the sides. You know that right bronchi is larger than the left. So there is always a chance for the ET tube to slip into the right side. So it is always ideal to pull or withdraw the ET tube once it is touching the carina. Pull it or withdraw it at least 4 centimeter above and then fix it. Now, LMA or the laryngeal mask airway is used for securing the airway of a patient in which of the following conditions? Option number 1, in a difficult intubation. Option number 2, in cardiopulmonary resuscitation. Option number 3, in a child undergoing an elective or routine eye surgery. And all of the above. What do you think? In all these situations, you can use an LMA. So, the LMA when you use, in which situation or pertaining to LMA, which statement is right? So, LMA is an ineffective alternative to endotracheal intubation. It should not be used in patients with cervical trauma. C. It causes respiratory obstruction in less than 10% of patients. It provides adequate protection against aspiration of gastric contents. What do you think is the answer? It causes respiratory obstruction in less than 10 patients. Remember, LMA is considered to be an effective alternative to ET intubation because it causes less injury to the throat and less complications. And for cervical trauma or cervical injury patients where you cannot make like a head extension and all, LMA is a very good option. And also it doesn't provide any protection against aspiration of gastric content, which is a disadvantage of LMA. Okay, so remember, many studies have proved that LMAs are effective alternative to endotracheal tubes, especially with failed intubation or when any cervical injury or cervical pathology exists where you cannot do a severe head extension. But it failed to protect the airway against aspiration. Now see the diagram. This is a pro-seal type LMA, pro-seal type laryngeal mask airway. Above what side is the arrow marked area of the airway positioned? Carina, upper end of the trachea, the vocal cords, above esophagus. What do you think is the answer? This to be fixed above what level? It should be fixed above the esophagus. The reason is the arrow in that picture what showing is an internal gastric tube or the drainage tube, which is the advanced form of an LMA. That's a LMA pro-seal type, which actually helps to aspirate the GI secretion. So in the pro-seal type, you can consider it as a reusable supraglottic airway device which incorporates a gastric drainage tube placed lateral to the main airway tube at it ends at the tip of the mask. So when you take both the pictures, the normal LMA picture when it comes, you know how to identify it. The pro-seal type is with an additional tube and also at the tip you can see a drain orifice. So this tube is the drain tube and this is the drain orifice which is fixed above the level of the esophagus. Pin index system is a safety feature adopted to prevent what? Option A, incorrect attachment of anesthesia mask. Option B, incorrect inhalation agent delivery. Option C, incorrect attachment of defibrillator. Option D, incorrect gas cylinder attachment. Guess what? In the anesthesia delivery, to prevent or to avoid incorrect gas cylinder attachment, the pin index system is considered to be a safety feature because it is designed to prevent an incorrect type of gas by pins on the yoke of the anesthesia machine made with holes drilled in specific positions on the valves of the cylinder, which prevents or which provides a mechanical means of preventing incorrect connection. So remember, the pin index safety system is to prevent using incorrect type of gas in anesthesia. Transpinoidal surgical approach is done to treat. If you know which is the important gland over this, then you will easily identify the answer. Option A, adrenal tumor. Option B, thymoma. Option C, pituitary adenoma. Option D, medulloblastoma. Guess what? Option C, pituitary adenoma, because the seat of pituitary gland is over the sphenoidal bone, or you can call the sphenoid bone, which is a bat-shaped bone which has a depression at the middle. You can call it sella turcica. And over which your pituitary gland is situated, right? So that's why the surgery is even called transpinoidal approach. Or even that sella turcica is otherwise known as hypophyseal fossa. So either transpinoidal surgical approach or a hypophysectomy. Both the terms it means it is pituitary adenoma or the resection of pituitary adenoma. Standard unfractionate heparin is preferred over low molecular weight heparin in DVT. If the patient is with a coincidence of that, means if the patient has an additional problem of what? Liver abnormalities, renal dysfunction, cardiovascular disorder, myocardial infarction. Guess what? Renal dysfunction. In renal dysfunction patient, low molecular weight heparin, like what you give subcutaneously, the low molecular weight heparin that is administered even for DVT and as a DVT prophylaxis, this is generally not preferred. So instead, unfractionate heparin is given. Which of the following is not a definite airway? Tracheostomy, orotracheal tube, nasotracheal tube, LMA or laryngeal mask airway, which is not a definitive airway. Guess? LMA. So which are the definitive airways? Definitive airways prevent aspiration of gastric contents and it allows for control of ventilation and permit delivery of oxygen. All these criteria to be met, and LMA will not prevent the aspiration of gastric contents. Otherwise, it's like a proceal type. So they include the definitive airways are endotracheal tubes, which could be nasotracheal or orotracheal, tracheostomy, cricothyroidotomy. These three are considered, or these four are considered to be the definitive airway. Please remember this. The most important laryngoscope or the most common laryngoscope blade used for adult intubation. The most common laryngoscope blade used for adult intubation is Macintosh type, Miller, Kessel, McCoy, which is the most common. Option A. And the most common are these two, A and B, and the B is the straight one for the adult. Very commonly we use is the A. A 54-year-old man intubated with 7.5 millimeter ET tube and he is on mechanical ventilation since 3 days. Endotracheal tube cough mesh pressure is 37 centimeter of water. Identify the ideal measure for this patient. So, what measure to be taken for this patient? Option A, change to tracheostomy ventilation. Recommend re-intubation with large size ET tube. Lower the cuff pressure. Withdraw the endotracheal tube and fix it. What do you think can be done for this patient? So when such question come, you need to see one important point that's given is the ET cuff pressure. So could be something related to ET cuff pressure, right? Yes. So for that, now to confirm the answer, you should be knowing the normal ET cuff pressure. So lowering the cuff pressure is the measure to be done. So why to be lowered? Because normal cuff pressure is 20 to 30 centimeter of water. 20 to 30 centimeter of water, if you convert it to millimeter of mercury, it comes approximately 15 to 22 millimeter of mercury, which is considered to be the ideal cuff pressure. If the cuff pressure is very low, the problems are microaspiration or aspiration, even PEEP won't be delivered properly, dislodgement of the ET tube, poor ventilation, and infections like VAP, ventilator associated pneumonia. If it is a very high pressure, what comes, it will be just giving strain on the trachea, causing decreased mucosal blood flow, tracheal stenosis and all. So these are the complications of high pressure and low pressure of the cuff. And the normal ET cuff pressure is 20 to 30 centimeter of water. And this is the cuff manometer, which helps to check the cuff pressure. The nurse review the ABG results of a patient and not the following results. pH 7.31, PCO2 53 mm of mercury, bicarbonate 23 milliequivalent per liter. This is interpreted as. So check the ABG value properly. It's a compensated metabolic acidosis, uncompensated metabolic acidosis, compensated respiratory acidosis, uncompensated respiratory acidosis. What could be the answer? So how to identify the answer? First you check the pH. Then you decide whether it is acidosis or alkalosis. pH is 7.31. So normal pH is 7.35 to 7.45. Now it is less than normal. That means it's acidosis. It could be whatever, it's like an acidosis only. All your options are acidosis. Now check your PCO2 and bicarbonate. Bicarbonate normal is 22 to 26, right? So bicarbonate is normal here. Then PCO2 53. So what is normal PCO2? 35 to 45 millimeter of mercury. Here it is high. So increased PCO2 and decreased pH. So that shows it is a respiratory acidosis. So you fix as respiratory acidosis. You have got two options of respiratory acidosis. Now whether it is compensated or uncompensated, how to differentiate whether it is compensated or uncompensated? Now for that you need the third value. Bicarbonate is still normal. It has not started compensating. So it is not a partially compensated also. It is uncompensated completely. Uncompensated respiratory acidosis is the answer. Which of the following substance that decrease pain transmission and causes an inflammatory response? Substance P, histamine, prostaglandin, endorphin. Guess what? Endorphin. Now, endorphins are natural painkillers. It increases the mood and cause inflammatory response. When you give morphine and all, endorphins will be generally increased. And prostaglandins reduce inflammation and it increases pain. Substance P is just a neurotransmitter and a neuromodulator. Histamine, you know, it regulates the secretion of gastric acid, inflammation, and the regulation of vasodilation and bronchoconstriction. With that, we are completing today's video. Thank you so much for your patient listening. Tomorrow again, I'll be back with a few more MCQ. Thank you.